is Mike Thompson. Thank you all for joining us today for today's HSRQ Clinical Lecture Series. Today we're joined by Dr. Michael Hung, who is going to be talking about exploring the role of race in nephrology. Dr. Hung graduated from the Boston University School of Medicine, and after finishing internal medicine training at University of Cincinnati, he completed fellowship training in nephrology here at U of M. He's been a member of the faculty here since 2005 and currently serves as the Associate Division Chief for Clinical Affairs in the Division of Nephrology. And his primary clinical and research interests are in the areas of acute kidney injury and critical care nephrology. I know, Dr. Hung, you work with Donnie quite a bit and in many areas around AKI, so we're very interested to hear your insights here today. And before we turn it over to you, just a few kind of usual housekeeping items. This is a webinar, so you shouldn't have to worry about your audio or video. This will be recorded, so if you have any concerns, please go to the chat and let us know or reach out to us afterwards. There will be one contact hour for CME for today. Here are disclosures for that CME credit. This is the QR code. I will bring this back up at the end, just so that if you were unable to get it now, you can always check it out later. So thank you for attending. Our next one will be at the end of March with Dr. Jesse Golbis, and so we're looking forward to that as well. If you have any questions or suggestions for future topics or speakers, feel free to reach out to us. We're always looking for input and questions about who might be helpful to have here. So thank you again. And at this point, Mike, I will turn it over to you.
Great, thank you. I'm just going to pull up my slides here. So thanks very much, Mike, for the kind introduction, and want to thank Donnie for the invitation to come speak on a topic that I think is a pretty important and evolving one, which is the role of race in nephrology. These are my disclosures, nothing relevant to this presentation. And I thought I would just start by, why are we talking about race in medicine in general? And obviously in the last couple of years, between the pandemic wasn't the only epidemic going on. I think there's a lot of reckoning going along with racism in society, obviously. And medicine has been part of that as well. And more specifically, the role of using race in various clinical algorithms or other formula in medicine has really come under more scrutiny, and I think appropriately so. So a lot of discussion, particularly in the area of nephrology as well, and so and a lot of change. And so I thought it would be a good to cover some of those aspects today. Some people have put forth concepts of what is the role of race in medicine, and I think most people believe there certainly is a role to looking at race. But when we do so, people have recommended guidelines such as making sure that this is used to confer benefit and substantial benefit that can't be achieved through other feasible approaches, recognizing that patients may not want to be put in a race category, and to be able to accommodate those patients fairly. And also to note that any use of race should be transparent. So I just wanted to kind of set this as the backdrop for the talk. And what I'm going to really focus on today is talking first about what I think is an example of appropriate and hopefully beneficial use of race in medicine, which is the examination of racial disparities in nephrology. And then for the second half of the talk, a kind of transition to talking about what is the role of race in estimating kidney function, or what it has been traditionally, and that might be an example where maybe the race is not as appropriate in medicine, and we'll talk about the changes that have happened and potentially what the impact of those are. And throughout this talk, please jump in with any questions or clarifications. I'll do my best to keep an eye on the chat or other things. And others can interrupt me anytime to ask questions along the way. And actually, there should be plenty of time at the end. I'm really hopeful to get your guys' feedback in terms of, potential interesting areas to look at, because again, a lot has changed in recent times. So first, looking at racial disparities. It's been well known for quite some time that there are significant disparities along racial lines for both chronic kidney disease and end-stage renal disease in the United States. Black or African Americans patients are 13% of the US population, but nearly 1/3 of our patients with end-stage renal disease or kidney failure, and face a more than 4 times risk for end-stage renal disease compared to Caucasians. Has been a lot of work trying to look at what some of the reasons for that are. And certainly there are factors such as differences in common risk factors, such as diabetes and hypertension, that are more prevalent in Black and African American populations. The effect of socioeconomic factors, including access to care and other environmental factors. But I don't think that we truly know all of the, we can't explain away all of the differences. But again, I start with disparities as a potential good example of looking at race in medicine, because recognizing these disparities is obviously the first step in being able to do something about them. And this graph here, this comes from the USRDS, which is the United States Renal Data System. It's free data that includes all dialysis patients in the US pretty much, because they're all covered by Medicare. And for those of you that are interested in looking at kidney disease, it's a great place to start. There's a lot of epidemiologic stuff on there. This is a graph showing trends in end-stage renal disease incidence rate by race in the US population. And it's kind of a good news, bad news, or glass half full, half empty kind of view, because on the one hand, you can see the stark disparities between this bottom line here, which is the rate, the incidence of ESRD in white patients, versus the blue line up here, which is Black patients. It's a huge difference. At the same time, in recognition of these disparities, there's been a lot of work to try to close that gap a little bit. And you can see arguably the greatest improvements, by absolute counts at least, have come through for the Black population. And so clearly still a huge gap. So again, glass half full, the trend, hopefully glass half empty, still a lot of work to do to close these disparities. Similarly, when it comes to kidney transplantation, unfortunately, there are significant disparities. Black patients compared to white patients are 25% less likely to be listed for a kidney transplant, even after adjusting for comorbid conditions. They're, not surprisingly then, they're also less likely to receive a kidney transplant if they have kidney failure. And unfortunately, Black patients also have worse outcomes following kidney transplantation. So higher rates of delayed graft function, higher rates of acute rejection, and major outcomes of actual graft loss, 25% at 5 years compared to under 15% in white patients. And this, not surprisingly, also correlates with overall mortality rates after transplantation as well. At the same time, again, highlighting these disparities has hopefully led to improvements. For example, there have been changes in the organ allocation system over the past decade that have helped to close the gap a little bit. There were some recent studies that have shown that there's a trend towards improvement, a closing of the disparity gap between Black and white patients, although the gap still exists. It's also been helpful to do some further exploration. For example, this study, which is quite recent, showed again that you're less likely to be transplanted if you're Black compared to white. But what they noted was that this was not a significant difference for deceased donor transplant, and that the difference overall was really driven by decreases in living donor transplants. And so there's been more interest, more work to explore in communities of color why what are the barriers to living donor transplantation, understanding cultural differences, for example, or religious views and things like that, to try to hopefully overcome some of these barriers. So again, there's been some, by looking at these and uncovering these and exploring them, this has led to some improvements, although the gaps are still there. An area that I focus on is acute kidney injury, which is defined by a more sudden decline in kidney function, as opposed to typically a more gradual decline over years that we see with chronic kidney disease and end-stage renal disease. AKI, the time frame of that is typically over days to maybe weeks, or sometimes even hours. And like the previous areas we talked about, Black patients unfortunately have increased risk for AKI, and this has been described in a variety of different settings, from the general population to hospitalized patients after a percutaneous coronary intervention and after surgery as well. We don't fully understand the reasons for the disparity, although some studies have suggested a significant impact of socioeconomic factors. And people have raised the question of systemic racism. This is just a figure that really is a meta-analysis of a number of studies that shows the overall increased risk of AKI in African-American patients compared to white patients. So knowing some of these disparities in AKI, I had the opportunity recently to work with Donnie's group and look at the role of AKI after cardiac surgery and whether there were racial disparities there. Again, we know that there are some racial disparities in cardiac surgery outcomes, but those haven't been fully explained. And also what the impact of acute kidney injury, whether that's a factor mediating those outcomes, wasn't clear. So we wanted to specifically look at that. We used the PERFORM database of cardiac surgery for a 5-year period from 2014 to 2019. And this included 42 centers that are part of the registry. We focused on patients undergoing CABG or valve surgery, and usual exclusions, patients that were on dialysis before or didn't have the serum creatinine data that we need to identify AKI. One thing we tried to do that was relatively novel was we looked at patient factors, of course, demographics, comorbidities, known risk factors for AKI. But because of the richness of the PERFORM database, we were also able to look at intraoperative practices, some of which have also been described to be risk factors for AKI, but haven't been fully explored to try to explain some of the differences in outcomes. So we're very fortunate to be able to look at that data in detail as well. The primary outcome we focused on was acute kidney injury. We focused on more moderate to severe AKI, not just all AKI, including mild AKIs. And that we define that as what's called stage 2 or worse AKI. That's at least a doubling of the serum creatinine from baseline, which more or less represents at least a 50% decline in kidney function. So the results, we were able to look at 34,000 plus operations, and approximately 8% of these were Black patients. Looking at the baseline characteristics, we saw a lot of differences between patients at baseline. For example, Black patients had a lower rate of elective surgery, which means they had more urgent or emergent surgeries, which would maybe tip the scale towards higher risk for AKI. Conversely, white patients tended to have a slightly lower baseline GFR, although these differences, you could argue these differences may not be as clinically significant, even though they're statistically significant. But nonetheless, a lower GFR at baseline would typically be a risk factor for acute kidney injury. But then the Black patients tended to have higher comorbidities, such as diabetes, peripheral vascular disease, heart failure. And all of these could be, have been described as risk factors for acute kidney injury as well. So clearly not starting on an equal footing at baseline. In terms of the intraoperative factors, we saw some differences in terms of perfusion time and cross-clamp time, although talking to my colleagues, the perfusionists, I don't think most people felt that these were, did not think these were clinically significant differences necessarily. For example, you know, a 3-minute difference, is that enough to be the difference in significant kidney risk? Most of us wouldn't think so, although we still nonetheless adjusted for these factors when I talk about the outcomes analysis. Also, interestingly, higher rates of ultrafiltration, lower nadir hematocrit during the operation, and a higher rate of red blood cell transfusions. So all of these factors tend to be associated with increased AKI risk. So putting it together, what we observed was crudely an overall incidence of 4.9%, nearly 5% in AKI after the surgeries in this analysis. And it was very different by race. It was 8% among the Black patients compared to 4% among the white patients. Not surprisingly, because this has been described over and over, AKI was associated with a significant increased risk for mortality, hospital mortality. And the risk was actually fairly similar between Black patients and white patients, about 16 times higher compared to not having AKI in both race groups. So AKI is bad. That's why I've been so interested in it. It really, if I forgot to mention that, AKI is associated with a very significant worsening of outcomes, and we definitely saw that. Interestingly, again, the relationship didn't seem to be different between Black and white patients, but the risk for AKI was higher in the Black patients. And after adjusting for all those factors that we looked at in the previous couple of slides, both patient factors such as comorbidities, as well as differences in intraoperative practices, Black race remained an independent risk factor with an adjusted odds ratio of 1.5. So still a 50% increased risk for AKI, despite accounting for the factors that we had access to. So from this study, clearly there are some limitations, most notably the risk of residual confounding. One of the key things that we could not adjust for was the role of socioeconomic factors. It's just not really available in the database at this time. And that's something that I think is a really interesting aspect moving forward. For example, in the state of Michigan, one of the brand new CQIs is called M-Shield, that you may be familiar with, which is really focusing on social determinants of health. So I'm hopeful that down the line, M-Shield is going to be, M-Shield will be a partner to all of the other CQIs, including the MST CVS QI for the PERFORM registry, and hopefully we'll be able to examine the impact of the socioeconomic factors here. So that's an important caveat. More studies are needed to understand what are the reasons between the disparities we saw in terms of the operative practices. I will say that when we had some discussions with some of the surgeons and perfusionists in the group, there was surprise in terms of seeing these differences by race, and nobody had any explanations for why, no thoughts in terms of I would do something different because a patient was Black or not Black or anything like that. So clearly a little bit more to understand why some of those differences played out. And I'd like to think this is hopefully a potential QI opportunity for the cardiac surgery quality initiative as well in the future. So I'm going to shift gears a little bit now and talk about race in kidney function estimation. And so hopefully in the last section, I was able to show that examining race can lead to important information about understanding disparities and hopefully begin the journey to eliminating those disparities. This is maybe a little bit of a different story. So first, what is glomerular filtration rate? GFR is what the variable that we use to describe basically how well a person's kidney is functioning. Although this is just one way of assessing the kidney, and filtering is only one of the many functions of the kidneys. This is basically GFR equates with kidney function. And so the clinical utility of GFR is basically throughout medicine, not just nephrology. It's used to help define and classify chronic kidney disease, and also to help chronic kidney disease prognosis. For example, this is a heat map looking at the risk of progressive kidney failure. And the rows here define the levels of chronic kidney disease, G1 through G5. And these are defined by the GFR categories or the GFR level. The other categories, the columns here we look at, are the albuminuria categories. And so the more albumin you have in your urine, the higher your risk for progression as well. But not surprisingly, going from top to bottom, you're going from lower to higher risk of progressive kidney failure. GFR is used as a monitoring metric for kidney function. It's also used to determine dosing for drugs that have renal clearance, and therefore in patients with impaired renal function need to be dose adjusted. It's used in guidelines for a number of clinical recommendations, including for referral to nephrology and management of chronic kidney disease. And it's also used to determine kidney transplantation eligibility. So again, pretty pervasive in clinical medicine for GFR. So how is GFR defined or measured? There's something called inulin clearance, where you can give a molecule inulin that is filtered by the kidney, and then it just comes out in the urine. It is not, nothing else happens to it. It's not reabsorbed, it's not secreted, it doesn't come out any other way. So if you can measure the inulin clearance, it is an excellent surrogate for GFR. Similarly, iothalamate and iohexol are other elements that you can give that also are cleared the same way by the kidneys. And so basically you can measure the clearance of these, and it gives you a reasonable estimate of the GFR. The reason that's not the gold standard is because, for example, an iohexol plasma disappearance test can take up to 10 hours. You have to have an IV placed. They inject the iohexol, and then they take serial samples and map it on a disintegration curve, basically. And then based on a nomogram, can estimate your or calculate your GFR from that. So it's a very complicated type testing, pretty bulky, and that's why it's not the gold standard in clinical practice. The other thing you can do is measure creatinine clearance. Creatinine is something that is produced by muscle. It is cleared by the kidney, but it's also secreted by the kidney. So in addition to being filtered, it's then pumped out in the kidneys, and therefore it's not a perfect marker of GFR. In fact, by definition, it overestimates GFR. So there's caveats to that as well. So if we can't routinely measure GFR, how do we get a good estimate of GFR? Basically, the serum creatinine lab test is our main variable to try to estimate the GFR. And the way that is done is basically using a linear regression formula. So the original studies that tried to develop a formula for eGFR, one of the first ones was the MDRD study. This was basically a clinical trial that was looking at the assessment of diet. So MDRD actually stands for the modification of diet in renal disease. It's actually looking at whether protein restriction would delay progression of kidney disease. The reason it's relevant to us here is because in this study, they measured serum creatinine and a ton of other variables, but they also did the fancy test to measure GFR. And so they had the data, they had measured GFR, they had a bunch of clinical variables, and they were able to develop a formula from that to best fit that. And that became known as the MDRD equation. And that was the standard for quite a number of years in terms of estimating the GFR from a creatinine measurement. In 2009, a new consortium took data from the MDRD study, but also from several other studies. So it was pooled from pooled data, and they basically developed a new formula, same concept, using multiple linear regression. And you can see here, this is the formula they came up with. And I'll highlight that there is a correction factor for race included here. And it's basically times 1.159 if the patient is Black. So it's a binary Black or not Black factor. There was a race factor in MDRD as well, which is why they included it here. I want to point out this data because I think this is really interesting. I know there's a lot on this slide, but basically what each of these panels shows is the estimated GFR on the x-axis and then the measured GFR on the y-axis. And you can see that in the original MDRD study, as you went further up your GFR, there was a little bit further. This is the best fit line for the formula. You strayed a little bit further from perfect, the unity, perfect agreement between estimated GFR and measured GFR. And so that was one of the specific goals of the CKD epi formula. And when they did that, they were able to narrow this gap. So they were able to develop a more accurate formula. So that was the goal. But what I really want to show you with this is look at all this scatter. Okay, this is, so when we think about, we talk about GFR, and we sometimes argue between somebody's GFR 29 versus 30 or something like that. In the back of my mind, I can't not see this, which shows a huge amount of scatter here. And so, there's a little bit of false construct here, to be perfectly honest with this, in terms of false precision. And I'll kind of come back to that, but I wanted to show that here just so you have an idea of the differences there. I just want to briefly mention also cystatin C, which is unlike creatinine, which is generated from muscle, cystatin C is generated from all nucleated cells in the body. So it's not affected by differences in muscle mass between people. This has also been looked at as a marker for kidney function. There are formulas for that as well. And they have never included race in them. So this seems like a good alternative. It's something that I'll mention again later. But the challenge is not as ubiquitous as creatinine. It's not as well standardized, and it's not as available. It is in our system, and I order a number of these tests to clarify sometimes, but it's not ready for prime time to completely replace creatinine. So again, race as a component of GFR, how did that come to be? There is no specific rationale for why it was included in the original MDRD. It was included in CKD epi because of MDRD. And again, as you saw from the formula, basically what they found was that Black patients had a 16% higher GFR compared to non-Black patients for the same creatinine. And thus they just built in that 1.159 factor. Interestingly, again, the race variable came out as this Black or other. There weren't that many of the other races other than white to distinguish. And there's also no discussion about how to apply this for different African origins or multiple race individuals. So as we've, recognizing that race is a social construct and not a biological construct, it really comes to ask, why does it even make any sense to include race in a biological variable here? And this is a nice figure I like to show. This is how many people assume things are in terms of genetics, is that races are genetically different. But in reality, there's more genetic diversity within races than there is across races. And so again, the recognition now that race is more of is a social construct that was developed and not based in biology or genetics and biology. So what are some of the problems with the use of race in eGFR? So again, it's a social construct. There's not a biological explanation. We don't know why there were these differences by race. We don't even know how race was fully identified in those groups. They mentioned that is either assigned by the investigator or self-reported. It just seems unnecessary to have to identify and therefore separate people by race. And there's basically no established approach to patients of mixed race. And I think this is one thing that really struck me, having a patient come in and I have to decide whether they are a Black or not Black. I can ask them, but that's kind of awkward. And there's not a good explanation for that. And what if they are a quarter Black? What if they are half Black? What does that mean in terms of race? What does it mean if they are immigrated from Ethiopia versus if they are, born in the U.S.? There's no good answers to any of those things. And then perhaps most importantly, there's in some scenarios, there's a potential to disadvantage Black patients with this approach. So we'll go through some different scenarios to see how this is applied and what it means. Actually, before we go into those scenarios, in recognition of all these problems with using race in the formula, the National Kidney Foundation and the American Society of Nephrology have been working over the last year plus on finding a better way forward, basically. And after a lot of deliberation, they released their final report this past fall. And basically what they recommended was a new CKD-EPI equation that was basically retrofit without using the race variable at all. Okay, so they actually considered several different options, including just getting rid of the race variable. But the one they settled on was basically developing a new equation, which I'll show in one sec. I'll also point out that we were anxiously waiting this change and had thought of our many different ways that we ourselves could simply remove the race equation. But when this came out as a consensus recommendation, we adopted it. And for those of you that have clinical duties, you may have seen in labs that now the new GFR reporting has a big paragraph caveat to explain it and call attention to it. And that's what it's referring to here. That came into place, that went live at the beginning of the year. And so basically what they did, this is the original formula that was being used, the CKD-EPI. Again, this is the estimated GFR here, the measured GFR here. So the black line is the line of unity representing complete agreement. For non-Black patients, it's the orange line. You could see there was pretty good agreement with Black patients and this original, who have a slightly different formula with the variable. With that variable, there was decent agreement here, just a little bit of bias. One consideration was simply using the formula and saying, okay, we're just going to take out the race variable. We're going to report one variable. We'll not use the 0.159 correction factor. So if you do that, of course, it doesn't change anything for the non-Black participants, but it's going to shift all of the values of the Black participants by 16%. So not surprisingly, you introduce significant greater bias, lower classification to the Black patients. So it didn't seem right to just do that. So what they settled on was, again, looking at all the data, and basically they just took out race as a variable, and they created a new formula that only includes age and sex in the variables and the serum creatinine. And so under that new formula, they then went back and they applied it to the Black and non-Black participants. And basically you can see that for Black participants, the bias improved slightly from before and in a different direction. And you can see the line fit here. Whereas for the non-Black participants, arguably they introduced a bias, okay? So now the new formula changed the results for both Black and non-Black participants. But the overall characteristics are a little bit better when you take the overall. The other thing, again, similar to what I pointed out earlier, I'll point out again that the agreement within 30% of the measured GFR is pretty good, but this is within 30%, okay? So oftentimes we quibble over a couple of points of GFR, and it's important to remember that there's a significant standard error here. Okay, so going to scenarios, what does this actually mean when we're trying to take care of patients and try to understand what the impact is? So the first thing is referral to nephrology, generally recommended for patients whose eGFR has fallen below 30. In reality, we've seen more and more referrals for anybody whose GFR is actually less than 60 because that comes up flagged as abnormal. And that's the beginning of stage 3 CKD. So if we just look at the less than 60 threshold, one example, 55-year-old man comes in with serum creatinine of 1.4. Under the old system, the old formula, if you identified him as Black or he self-identified as Black, his calculated eGFR would be 65. And you would say, okay, that's maybe not CKD, we'll just watch him. Where if you identified him as non-Black, white, Asian, something else, his GFR for the same value is calculated at 56, in which case you would think about referring. And so this is an example of concerns that maybe one of the disparities was that Black patients were getting this boost inappropriately, and it was delaying timing of referral to nephrology. So with this new formula, the eGFR for everybody calculated from this, does not matter what your race is 59. And so you would refer. So hopefully we've shifted some patients towards referrals. I'll also point out that this is not a do-all end-all in terms of referral, and that trends are important. So just knowing what somebody's internal trend is, their creatinine over time, that's just as important in my eyes. So just thinking about what the epidemiologic impact of this is, our group here did an analysis of data from NHANES, which is survey data, but also has some lab data. And basically using the race and variables, we calculated what the difference is, what the difference would be in CKD prevalence if we just got rid of the Black race variable in the original CKD epi formula. So this is not the new formula. It's simply if we got rid of the old formula. So it would not affect non-Black patients, but Black patients, it would shift their GFR down, as you can see here, from the gray to the orange. And this delta actually came out to just short of 1 million patients that would suddenly be labeled with chronic kidney disease, okay? And again, that's important for public health purposes, potentially for resource utilization purposes. Hopefully in a good way, it brings more attention, more patients into appropriate care at an earlier stage when benefits are best. Interestingly, with the new formula, the one that I just presented, remember, the new formula lowers, it's not a perfect average, but it basically lowers the GFR compared to before for Black patients, but it raises it for non-Black patients to some degree. And therefore, with the new formula, you're going to have some of the opposite too, where some non-Black patients will no longer be classified as CKD. What about medication prescribing? As I alluded to earlier, a lot of drugs have at least partial kidney clearance and therefore need to be dose adjusted or maybe avoided in patients with chronic kidney disease. One example is metformin, which is an excellent medicine for diabetes, first-line medicine for diabetes, but contraindicated for patients who have a GFR less than 30. And so taking an example, a 42-year-old woman who has a serum creatinine of 2.1. If you identify her as Black, her GFR is 33, you can prescribe it or she can continue on that medicine. But if she's non-Black, her formula eGFR comes out as 28, and that's actually considered contraindicated, okay? So interestingly, if you use the new formula for this, the eGFR comes out to 30 for both of these, okay? And so technically you can still use it, it's right on the edge, but somebody who wasn't able to get this overnight because we changed the formula now technically qualifies, when obviously nothing changed about them, about their biology or anything. And so this raises interesting questions about, you know, how exactly we should handle these types of situations. And I don't think anybody knows the answer to that right now. In terms of real world impact, this was a really nice study that looked at the impact of FDA labeling changes. In 2016, before 2016, the labeling from the FDA was that creatinines greater than 1.5 in men or greater than 1.54 in women were contraindications for using metformin. After that, they updated it to using GFR criteria, which then kind of accounts for the gender differences, but also race at that time. And so it didn't make any difference in prescribing among patients with normal kidney function or mild chronic kidney disease. The black bars, by the way, represent Black patients, and the white bars are white patients. The only statistically significant difference was in patients in this chronic kidney disease group that really kind of straddles that threshold of 30. The prescribing in this group went up from 26% to 33% in Black patients. Slight dip, but not statistically significant difference among white patients after the labeling. So the concept here was that by labeling and showing that the GFR was above 30, uncovering that, especially for Black patients who got the boost, that actually led to less disparities and more prescribing. Now, again, whether this is appropriate or whether there could have been more side effects, this wasn't an outcome study. This is just looking at prescription. But again, trying to show both sides of the story here, that changes can be a double-edged sword. And so the most recent change could reverse, in theory, could reverse some of this effect. And again, medication dosing. Let's take a common drug like amoxicillin that does need to be dosed based on renal function. Again, 42-year-old female with a serum creatinine of 2.1. If Black, you would prescribe 875 milligrams. If non-Black, you would prescribe 500. Now, everybody with these values gets 500 based on this eGFR. So again, nothing's actually changed in the patients, but because of how we interpret the formulas or how we calculate it, it has changed. And so I think it really brings up a lot of interesting questions. Dialysis initiation. This is one I heard a lot, that Black patients were not getting started appropriately on dialysis. I tend to think this is less of an issue because basically because eGFR is not the main factor that we use. It's really based on symptoms. So once they get down to a certain level of kidney function, it's less about what any of their numbers are and more about how they're feeling. Also because when you think about the old formula with race, it's a 16% difference, which when you get down to low GFRs like 10, the difference is really pretty minimal. Okay, so I tend to downplay a lot of changes in terms of dialysis initiation being affected by differences in the formula. However, transplantation is potentially a significantly impacted. In order to be listed for kidney transplantation, you have to have a GFR less than 20. And so if you take a 65-year-old with a serum creatinine of 3.2, if they're Black, their GFR is 22, they cannot be listed yet. They cannot start accruing time for a transplant. Whereas if they're non-Black, they fall below that and they can get listed. And so this is one of the disparities that people talked about with the old formula. Interestingly, with the new formula, just for this particular example, the Black patient would still not get listed. And actually the non-Black patient would get pulled up and potentially is no longer qualified to be listed. So again, two sides to this as well. And living donors are also relevant. In order to be a living donor, you have to have a GFR greater than 80. And if you take a 40-year-old man with a serum creatinine of 1.2, a Black patient, that calculates to an eGFR of 87, which would mean they're eligible. But a non-Black patient would calculate out at 75 and potentially be excluded. With the new formula, it falls somewhere in between. It calculates out as 78. So actually, again, this has the potential to exacerbate a disparity by pulling Black patients out of eligibility. And as I showed earlier, living donation is one of the biggest gaps in terms of the transplantation. I will say that in our center, we actually measure GFR for confirmation. We don't put all of our weight on this. So I think in our center, it's less common, but not every center has the capacity to do the complicated measuring GFR measurements. And so it's actually most centers don't have that capacity. So again, it'll be interesting going forward to see the impact of this change. So in terms of next steps and future directions with this eGFR, this has not been universally adopted yet. As I mentioned, we have adopted it in our medical center, but the hope is that all labs will start reporting the same way. So at least there's consistency across labs and from center to center. Obviously, we want to keep searching for better formulae and markers of kidney function. And then what I'd really love your guys' feedback on is what is the best way to examine the real world impact of this change in eGFR reporting, which we have done in our medical center just 2 months ago. How is this impacting clinical decision-making, especially around those thresholds like I showed, like a GFR of 30 or referral thresholds, maybe around 60? What impact is this having on disparities, such as the transplant listing, like we just talked about? Currently, we're looking at the use of cystatin C and whether that goes up. So the impact on resource utilization, referral patterns. And one thing I'm also interested in is provider and patient perspectives, looking potentially at qualitative research approaches. Since this new formula came online, I've actually had several patients in clinic bring up to me unsolicited that they were very interested and pleased in most cases to see this change. And not just Black patients, Black and white patients who then said, honestly, I always felt uncomfortable seeing this Black, non-Black distinction in the reporting. So honestly, that made me feel pretty good to be part of this, to see that, but it'd be interesting to try to study that a little bit more. So just to summarize, a lot of, unfortunately, significant racial disparities in nephrology care and outcomes, but research looking into these disparities has helped to improve health equity, although there's still a long way to go. GFR is a really important clinical concept, but it's a flawed one, frankly, as I showed with the error. And we've talked a lot about eliminating race-based medicine, and I'm pleased that we've been able to do that here, and hopefully soon nationally with the removal of race from the GFR equation. But there are but I think it's still our responsibility to really examine what the actual clinical impact of that is, and hopefully demonstrate positivity from it. So thank you very much for your attention.